Hello, this is Dr. Kurt Trouble from the University of Mississippi dictating this talk for Dr. Mark Ferguson from the University of Chicago. Dr. Ferguson has graciously prepared this talk on the assessment of the thoracic surgery patient for operation for our TSDA curriculum.
A careful preoperative assessment of patients undergoing thoracic surgery is important in evaluating the risks of major postoperative complications. Such complications are not infrequent. After lung or esophageal resection, for example, pulmonary and cardiovascular complications occur at rates up to 20%. An appropriate pre-op assessment assists with identification of patients who are at increased risk and helps select patients who are able to undergo surgery safely. Rating risk helps with obtaining informed consent from patients. Those who are at increased risk may be provided with more intense postoperative monitoring or other resources to help identify and manage complications. Identification of increased risk may lead to alterations in the surgical approach or the extent of the operation.
Traditionally, much of the process of preoperative assessment has relied on a surgeon's intuitive judgment of risk, but this judgment is often far from reliable. It is prone to vary, particularly if there has been a recent unfortunate outcome or unexpected success. Risk assessment instead should be performed in a deliberate manner that is tailored to the individual patient's needs. Many routine assessments can be performed with the help of established algorithms which help ensure that key components of the evaluation are not overlooked. It is vital that values arising from objective assessments not be used as the sole criteria for determining a patient's eligibility for surgery. The surgeon's judgment, based on the preoperative evaluation, and the surgeon's training and experience, is the ultimate arbiter of whether to proceed with recommending surgery. A large number of factors need to be assessed for patients who are candidates for thoracic surgery. Some, such as age, performance status, and body mass index, require no specific testing. Others, particularly measurement of cardiopulmonary function, necessitate tests that are not done routinely other than for thoracic surgery. Most patients' history of other organ dysfunction can be evaluated with a carefully done medical history and perhaps some simple blood work. The diagnosis, the proposed operation, and the planned approach to the operation all factor into the risk assessment, as will be evident later in this presentation. Age is intuitively an obvious risk factor for major surgery. Age alone is not always indicative of risk. The physiologic age of the patient is a much more revealing risk factor, but it is difficult to assess accurately. Although improvements in patient selection and perioperative management has somewhat reduced the increased risks associated with advancing age, this factor remains important in risk assessment. The relationship of age to pulmonary morbidity and operative mortality after major lung resection is illustrated in this graph of unpublished data. Similar relationships are evident for other major organs and operations like esophagectomy. Performance status using the ECOG or Karnofsky scales is easily and reproducibly assessed during a standard history and physical examination. There is marginal difference in outcomes after major surgery among patients with a performance status of 0 or 1. In contrast, a performance score or performance status of 2 or more is associated with measurably poorer outcomes for operations such as lung resection and esophagectomy. Cardiopulmonary status is the most important determinant of risk for the overall population of patients undergoing thoracic surgery. A general impression of cardiopulmonary status can be gleaned during a standard history and physical exam. Specific factors that are related to increased risk are listed here. If there is evidence for the existence of any of these risk factors in a patient in whom major surgery such as lung resection or esophagectomy is contemplated, additional evaluation is usually indicated. Note that peripheral vascular disease premature ventricular contractions, and even atrial fibrillation do not appear to increase the risks of thoracic surgical procedures. Assessment of cardiopulmonary function is appropriate for most patients undergoing major thoracic surgery. This does not necessitate formal testing for many patients, as an accurate estimate of cardiopulmonary status can be gleaned from a standard history and physical examination, perhaps with the inclusion of an electrocardiogram. Specific questions regarding symptoms of myocardial ischemia, stair climbing ability, energy levels, and exercise tolerance in general should be addressed. Most of the three specific components of cardiopulmonary function, that is, ventilation, gas exchange, and pump function, need to be individually assessed if there is evidence for cardiopulmonary dysfunction or for patients who are undergoing major surgery such as lung resection or esophagectomy. Ventilatory function should be assessed as part of formal pulmonary function testing using plethysmography rather than simple office spirometry. The more detailed testing provides information on total lung capacity, or TLC, and residual volume, or RV, which help determine the severity of underlying COPD or restrictive pulmonary diseases. Assessment of airflow includes parameters such as forced vital capacity, or FVC, and the forced expiratory volume during the first second, or FEV1. Most current software will compute FEV1 expressed as a percent of predicted, which incorporates height, sex, age into the calculation and normalizes values for purposes of estimating risk. Under most circumstances, FEV1% is the most important spirometric value to assess. The most common pulmonary condition affecting patients undergoing thoracic surgery is COPD, and the most common type of COPD we see is emphysema. An understanding of the relative degree of emphysema is important to have preoperatively. Moderate to severe emphysema is defined as an FEV1 less than 80% and an FEV1 to FVC ratio of less than 75%. Patients with a moderate to severe case of emphysema not only have poor outcomes after major thoracic operations such as lung resections and esophagectomy, but have a decreased life expectancy as well. An example of the effect of spirometric values on outcomes after major lung resection is illustrated here. As the FEV1% decreases, there is a corresponding increase in pulmonary morbidity and operative mortality. The relationships are not linear, as one would normally expect, likely because of biases in selecting patients for surgery. Gas exchange is best assessed with measurement of diffusing capacity for carbon monoxide, or the DLCO. A low-cost method of assessing the adequacy of gas exchange is to measure oxygen saturation during exercise. In most people, oxygen saturation will increase with exercise, but in those with very poor DLCO, oxygen saturation will decrease with exercise. DLCO is under-recognized as an important determinant of outcomes after major thoracic surgery, including lung resection and esophagectomy. It is not generally known that DLCO is also an important independent determinant of long-term survival after major lung resection, having an effect similar to age and cancer stage. The potential benefits of measuring DLCO are sometimes not well understood, as the finding of normal spirometry may suggest that the additional measurement of DLCO is unwarranted. As a matter of fact, spirometry and DLCO are not closely related, as can be seen by this scattergram plotting FEV1% against DLCO%. Thus, many patients with normal spirometry can have compromised gas exchange. DLCO is useful to measure in most patients undergoing lung resection or esophagectomy, and is particularly important to measure in patients after induction therapy. About 20% of patients have substantial compromise of DLCO immediately after induction therapy, and this change has been shown to adversely affect postoperative outcomes. An example of the relationship of DLCO to outcomes after major lung resection is illustrated here. The overall outcomes are depicted in the black bars, showing an increase in pulmonary complications as DLCO percent decreases. Interestingly, patients with and those without COPD demonstrated a similar linear relationship between DLCO and complications, although the absolute incidence of complications was lower in the group without COPD. There is a similar relationship of DLCO to operative mortality after major lung resection. One of the ways of more accurately assessing operative risk relative to lung resection is to estimate the predicted postoperative function. Examples are PPO FEV1 percent and PPO DLCO percent. The value of this is that the calculation includes the amount of lung to be resected, and thus risk is based not on what function the patient starts with, but the function the patient is expected to end up with after surgery. It is important to note that regional variations in lung function can affect the accuracy of these estimates, and these estimates are known to be very inaccurate at times in patients with the most severely compromised lung function. There are a number of reasons for regional variations in lung function, including underlying chronic lung disease, acute lung diseases, airway obstruction, decreased lung volume as a result of pneumothorax or effusion, and prior lung surgery. Estimation of predicted postoperative values is usually done very simply using the functional segment technique. Simply divide the number of segments remaining after surgery by the overall number of original functioning segments to get a percent of lung function remaining. Then multiply that percent by the preoperative values for FEV1 percent and DLCO percent to get the predicted postoperative values. For example, a patient undergoing a right upper lobectomy who would lose 3 of 19 functioning segments will have 16 of 19 segments remaining, or nearly 85% of baseline function. However, if only 2 of the resected segments were functional, then the remaining function is 16 of 18, or 89% of baseline function. A faster way of doing this is to assume that each functioning segment represents about 5% of lung function. In patients with heterogeneous function and those who have compromised lung function, it is often useful to improve the accuracy of predicted postoperative outcome estimations using functional studies such as a quantitative VQ scan or a quantitative CT scan to assist with estimating how much functioning lung will be removed. Unfortunately, the accuracy of PPO estimates is particularly poor in the group of patients in whom it is the most important, those with severe emphysema who are borderline candidates for major lung resection. And these patients, resection of the area most affected by the underlying lung disease may actually increase postoperative function compared to preoperative function, particularly for spirometric values. Targeting such areas, as is done in lung volume reduction surgery, is sometimes feasible for appropriately located cancers. Careful patient selection is mandatory, but there are no well-defined guidelines at present for how to identify optimal candidates for this approach. Assessment of cardiovascular function is vital prior to any major thoracic operation. Much of the assessment is performed as part of the standard history and physical, possibly with the inclusion of an EKG. Selection of patients who require additional evaluation is usually straightforward and based on the presence of specific risk factors or elements of the history. Advanced age, poor performance status, higher risk operations, or more advanced cancer stage may by themselves be an indication for additional testing. An algorithm for cardiovascular testing has been in use for several years and is quite reliable in appropriately selecting patients for additional evaluation. A risk index is determined based on the extent of the surgery and the presence of specific risk factors, as seen in the gray box on this slide. This index and other specific factors in the history may trigger non-invasive testing, which in turn suggests the need for additional testing, drug intervention, or proceeding directly with surgery. As an aside, percutaneous coronary intervention, which often requires long-term administration of antiplatelet agents, no longer necessitates delaying surgery for 6 weeks or more, as long as the surgeon feels the operation can be performed safely while the patient is on these medications. In patients in whom cardiac function is satisfactory but pulmonary function is of concern, especially those being considered for major lung resection, assessment of overall cardiopulmonary function using exercise testing is appropriate. Such testing assesses each of the 3 interrelated components of cardiopulmonary function, including ventilation, gas exchange, and pump function. Testing is sometimes not possible because of orthopedic or other limitations. Low-tech testing, such as the 6-minute walk or stair climbing, is useful in determining whether patients require high-tech testing. High-tech testing is usually performed using cycle ergometry with measurement of peak VO2 or oxygen consumption. A value above 15 milliliters per kilogram per minute is often considered satisfactory for major lung resection. An overall pulmonary assessment algorithm has been suggested by a task force from the European Respiratory Society and the European Society of Thoracic Surgery. Patients who have a normal FEV1% predicted and a normal DLCO % predicted require no additional pulmonary evaluation. Those who do have compromised lung function undergo exercise testing. If this exercise testing is satisfactory, no additional testing is needed. For those patients with severely compromised performance on exercise testing, standard surgery is not recommended. For those with intermediate results on exercise testing, assessment of regional lung function is performed to better estimate postoperative function before final recommendations are made. Outcomes of major lung resection are closely related to results of cardiopulmonary exercise testing. This graph demonstrates a linear relationship between declining peak VO2 and increasing pulmonary, cardiac, and overall morbidity and increasing operative mortality. Generally speaking, patients with a peak VO2 greater than 20 millimeters per kilogram per minute are in a good surgical risk category, whereas those with a peak VO2 less than 10 milliliters per kilogram per minute are in a prohibitive surgical risk category. Dysfunction of other organs can have important consequences on otherwise straightforward thoracic procedures. In addition to immune compromise, anemia, and the need for dialysis, renal failure at times limits fluid resuscitation. Hepatic insufficiency can cause alteration of mental status, platelet counts, and other coagulation factors. Immune suppression has obvious effects on susceptibility to infection. Suppression of normal responses to infection makes the diagnosis difficult and outcomes more serious. The extremes of body mass index can affect surgical outcomes, of course. Patients with a very low BMI are often nutritionally depleted, leading to poor performance status, weakness of muscles, especially those of respiration, and relative ineffectiveness of the immune system. Conversely, Patients at the upper extremes of body mass index have mechanical issues with spontaneous ventilation, are relatively immobile, and are at quite high risk for thromboembolic disorders. These factors adversely affect outcomes after major lung resections, as illustrated by these unpublished data, and have similar effects on the outcomes of other major thoracic operations. A diagnosis of cancer often carries with it predisposing factors for increased complications after major thoracic surgery, such as the combination of weight loss, nutritional and immune compromise, and decreased performance status. In addition, the presence of cancer increases the risk of thromboembolic phenomena owing to the presence of the hypercoagulable state often associated with cancer. The incisions chosen for thoracic operation can markedly and immediately diminish ventilatory function, particularly thoracotomy and laparotomy approaches. The decrement in function can be as much as 65%, and the gradual return to baseline can take up to 2 months. Using muscle-sparing approaches for thoracotomy incisions mitigates these effects somewhat, though not entirely. Much of the detrimental effect of thoracotomy and laparotomy can be nearly eliminated through the use of appropriately chosen minimally invasive approaches. There are reliable methods of altering individual patient risk, although most methods are not applicable to most patients. For example, those patients who are deconditioned may benefit from a period of cardiopulmonary rehabilitation as long as the delay in getting the patient to surgery is not contraindicated by the indications for surgery. Smoking cessation is perhaps the most important risk reduction technique, and with proper motivation, almost every patient should be able to stop smoking 2 to 3 weeks preoperatively. It is known that if the patients do not stop for this period of time or longer, that smoking cessation is counterproductive. Prophylaxis for deep venous thrombosis and antiarrhythmic medications should be considered routine in appropriately selected patients. Finally, consider altering the operative approach or the extent of resection in selected patients. In summary, the preoperative evaluation of thoracic surgery patients is vital for a number of reasons. It helps identify patients at increased risk, and it helps in the selection of patients for surgery. Truly informed consent is possible only when the surgeon and the patient are aware of the likely risks and outcomes. Furthermore, patients at increased risk may be assigned additional resources for perioperative management. Risk assessment involves evaluating a large number of factors, including age, performance status, all 3 aspects of cardiopulmonary function, and other organ dysfunction, and should be tailored to the individual patient. Risk can be mitigated somewhat through careful preoperative preparation and through changes in the extent of or the approach to the operation. Again, this was a talk put together by Dr. Mark Ferguson from the University of Chicago.